This causes hyperpigmentation. All right, what about the hyperandrogenism caused by all the precursors being shunted over towards the androgens? Well, the findings there depend on if you're a developing girl or boy. And all of this can be occurring secretly in utero, by the way. These are congenital enzyme deficiencies after all. Females with severe disease are born with ambiguous genitalia. Just think of this ambiguous question mark block getting butt stumped by Princess Nectarine over here. There can even be hyperandrogenism severe enough to cause labial fusion, making sex determination pretty difficult without chromosome analysis. In milder forms, CAH in females causes precocious pubic hair development or clitoromegaly in adolescence. These changes are embodied by Desmond's twin bro, Westmond, with that famous enlarged nose and precocious mustache. And in even milder forms, we see other usual symptoms of hyperandrogenism, including hirsutism, remember, mustache, and acne, as depicted by those majestic 16-bit Whitehead mountains in the distance. Man, those 7-mode graphics. So immersive. Females can also have irregular menses and infertility. Just think of those irregularly distributed red coins coming out of that item block. Males with CAH handle the extra testosterone a little better, with signs of hyperandrogenism usually presenting later in life as precocious puberty, with early pubic hair growth and phallic enlargement. Again, think of that big dong nose and mustache up there. Notice that the symptoms of hyperandrogenism in CAH can be similar to those seen in Cushing syndrome. So always keep in mind adrenal pathology when you're faced with a patient exhibiting signs of hyperandrogenism. All right, CAH and hyperandrogenism, I get it. But how do we tell the difference between 21-hydroxylase deficiency and 11-hydroxylase deficiency? First off, it's good to know that 21-hydroxylase deficiency accounts for greater than 90% of cases. Also, recall that 21-hydroxylase has two main enzymatic responsibilities: conversion of progesterone to 11-deoxycorticosterone in the zona glomerulosa gem cave, and conversion of 17-hydroxyprogesterone to 11-deoxycortisol in the zona fasciculata forest. So deficiency in 21-hydroxylase means that no aldosterone or cortisol can be made, and the precursors are shunted towards androgen production. We'll emphasize this with the broken mineralocorticoid crystal next to Dinky Kang and this chomped glucocorticoid moonfruit next to Danky Kang. No aldosterone means decreased ability to reabsorb sodium and excrete potassium in the distal nephron. So, the first classic finding to look out for in the setting of hypoaldosteronism is hyponatremia, symbolized by these falling salty sodium peanuts popping out of Dinky's peanut gun. Infants with 21-hydroxylase deficiency are referred to as the salt wasters of CAH. You might be thinking to yourself, wait, sodium wasting only affects volume, not sodium concentrations. And you'd be right. Like we explain in our Addison sketch, excess sodium excretion leads to volume excretion. But in the setting of hypovolemia, the brain sends ADH to the rescue, represented in our last sketch by that ADH water cooler. ADH conserves free water at the collecting duct, which in turn dilutes your sodium, and voila, hyponatremia. Another classic finding in the setting of hypoaldosteronism is hyperkalemia. This is, again, due to decreased function of the sodium-potassium exchangers in the collecting duct. The acidosis seen in hyperaldosteronism is technically a type 4 renal tubular acidosis, and has a complex mechanism of involving hyperkalemia causing decreased ammonia production in the renal tubule. For now, just think of this acid volcano eruption in the background. And check out the renal tubular acidosis sketch for more info on hypoaldosteronism and type 4 RTA. Kids with 21-hydroxylase deficiency also present with hypotension, represented by the fainting Danky Kang over there on the right, and even hypovolemic shock, as represented by his lightning bolt-shaped tail. Hypotension and shock are due to the combined effects of hypovolemia from aldosterone deficiency and decreased vascular tone from cortisol deficiency, just like we saw in the Addison sketch. If you need help narrowing your differential, look for increased renin in the setting of 21-hydroxylase deficiency. With aldosterone gone and all that volume wasted, the JGA in the kidney turns up the renin-angiotensin cascade in a vain attempt to wake up those adrenals. Increased renin is, as always, depicted by our renin rain umbrella. All right, let's move down one level to catch up with Marius and Louis, who were showing some of the signs of the less common 11-hydroxylase deficiency. Looks like it's game over for these two. Game over. I'll see myself out. First, recall that 11-hydroxylase is responsible for the conversion of 11-deoxycorticosterone to corticosterone in the zona glomerulosa cave, and the conversion of 11-deoxycortisol to cortisol in the zona fasciculata forest. And even though 11-hydroxylase deficiency affects the very next step in the pathway below 21-hydroxylase, the two types of CAH actually present much differently. Alright, so like last time, there will be little or no production of aldosterone or cortisol, as represented again by the broken mineralocorticoid mineral crystal and the chomped glucocorticoid moonface fruit. Seems no different from last time. The thing to focus on here, though, is that 11-hydroxylase deficiency causes a buildup of 11-deoxycorticosterone. This makes sense. Block a step and everything behind it backs up. Well, 11-deoxycorticosterone can actually exert mineralocorticoid effects. In other words, what you have here is a molecule floating around that mimics the effects of aldosterone. This is why we gave that turtle up there mineralocorticoid crystals on his back. Patients with 11-hydroxylase deficiency, therefore, present with symptoms characteristic of hyperaldosteronism, even though aldosterone itself is low. So look at that high-pressure steam coming from Michelangelo's ears. Increased mineralocorticoid action causes hypertension and hypokalemia due to increased sodium-potassium exchange and conservation of volume at the collecting duct. A banana peel? Really? That's what did him in? You can see other symptoms of mineralocorticoid excess as well, such as metabolic alkalosis. Check out our next sketch, Journey to the Center of the Adrenal, for more info. In contrast to 21-hydroxylase deficiency, kids with 11-hydroxylase deficiency have suppressed renin levels, hence that falling renin rain umbrella. Just think of all that volume retention and hypertension we were talking about. Increased perfusion of the GJA decreases renin release. Okay, so now that we know the symptoms, how are these neonates screened and diagnosed? The best first step is to look for which specific substrate is increased in the serum. Remember, block a step and everything behind it builds up. The first diagnostic finding in both 21 and 11-hydroxylase deficiencies is a buildup of 17-hydroxyprogesterone. That sunglasses sporting super rad turtle guy. He's a precursor substrate for both enzymes, and we've highlighted him by adding an opening in the forest. The levels of 17-hydroxyprogesterone will actually be much higher in 21-hydroxylase deficiency since it's a direct substrate for that enzyme. But there's another way to differentiate 21 from 11-hydroxylase deficiency. Since 11-hydroxylase deficiency blocks the step that's one level lower, expect a buildup of 11-deoxycorticosterone and 11-deoxycortisol. Both are a deoxy blue color and wearing those 11 suspenders. Remember? In pregnant women with a history of a child or relative with CAH, the same measurements can be made via chorionic villus sampling during the pregnancy. There are confirmatory genetic tests, but they're costly and usually not needed. Treatment of CAH is pretty intuitive. Give drugs with both mineralocorticoid activity and glucocorticoid activity for 21-hydroxylase deficiency. Just glucocorticoids for 11-hydroxylase deficiency. They got the mineralocorticoids covered. Remember that high-pressure steam? Oh, shoot. How much time is left? Gah! All right. Time to wrap this thing up with a much rarer form of CAH, 17-hydroxylase deficiency. That's right. We're talking about deficiency in those enzymes symbolized by the green teleport pipes that shunt precursors from the zona glomerulosa cave into the zona fasciculata forest, and then on towards androgen production. Notice that we put those sunglasses on the stone stomp, highlighting the number 17. 17 for 17-hydroxylase deficiency. Also, take a look at where that stone stomp is blocking our progress. In infants with 17-hydroxylase deficiency, all the steroid precursors are effectively trapped inside the glomerulosa gem cave, leading to high levels of aldosterone, but deficiencies of both cortisol and androgens. This is why we've put those mineralocorticoid mineral crystals on the top of the stomper. It's all aldosterone from here on out. These patients have the classic findings of hyperaldosteronism. The same symptoms exhibited by angry hypermineralocorticoid Marius down there. This includes hypertension, hypokalemia, alkalosis, and decreased levels of renin. We won't symbolize them all again here, but we will make the stomper angry with all that high-pressure steam. Now, the lack of androgen production in the setting of 17-hydroxylase deficiency has a slight twist to it. Of course it does. 17-hydroxylase isn't just important for producing androgens in the adrenals, but also in the gonads. Just think of these two cracked dino eggs that are shaped kind of like two ovaries or testicles, unable to synthesize their hormones. As you can imagine, deficiency of androgen production from the gonads themselves is going to be way worse than the missing weak androgens we were dealing with earlier. With decreased testosterone production in the testicles, males present with ambiguous or even phenotypically female genitalia. So we've brought in a male dino buddy who's butt-stomping the ambiguous question mark block. Some patients may even be raised as phenotypic females and diagnosed with CAH because of hypertension developing in their teens. Now, for females, a deficiency of 17-hydroxylase in thecal cells of the ovary means they can't produce androgens either. So there's no androgens for the granulosa cells to convert to estrogens, which are needed for the development of secondary sex characteristics, or a normal menstrual cycle. So females with 17-hydroxylase deficiency will have phenotypically normal genitalia, but minimal body hair and breast development. Notice how this female dino buddy wears the crossed-out smiley face shirt, a recurring sketchy symbol for decreased development of breasts and other secondary sex characteristics. Females with 17-hydroxylase deficiency also show delayed menarche or amenorrhea, as depicted by the female dino buddy's white underbelly. For more info on the clinical signs and symptoms and other causes of hypogonadism, check out the What?